I want to welcome Dr. Sarah Onida, who's an honorary senior lecturer at the Imperial College of London and also a consultant at the Imperial College of Surgery. More importantly, she's um, really one of the leaders, not only in clinical basic science and translational venous research, but one of the rising stars in our field. Thank you for agreeing to this podcast.
Thank you very much for having me. I'm delighted.
So can you tell us a little bit about some of the work you've been doing recently in the basic science lab? It sounds really interesting.
Yes, of course. So I'm very fortunate to have some excellent students and collaborators. So I'll be presenting some of their work, just to let you know some of the latest work that we've been clearly carrying out here at Imperial. But before sort of going into any detail about the science, really, this is about personalizing medicine and making sure that the treatments that we deliver to our patients are right for them, as opposed to a one-size-fits-all approach. And that's really important in vascular surgery in general. Clearly, we spend a lot of time talking about venous disease, but actually it's very applicable to diabetic foot disease, carotid disease, atherosclerosis, limb reperfusion, acute limb ischemia, post-thrombotic syndrome, etc., etc. And really the area where we have been working on the most is mass spectrometry, which is a technology, it's a platform that allows us to get some really detailed information about some of the molecules and the chemicals that are present in tissues or in biofluids. And it's quite cumbersome experimental analysis. When you take standard mass spectrometry, you need to go to the lab, you need to pipette the samples, you need to run the experiments. And if you have lots of samples, the experiments can last for days and days on end, and you literally have to be on call for the machine to make sure that there's no issues. And really that doesn't quite fit in with translational research with respect to bringing all that data to the patient's bedside, because you're not going to be able to step out and do all the experiments for hours and hours. You want the answers immediately. So there's been a lot of innovation with respect to trying to get some of these mass spectrometry platforms to provide data in the immediate setting, as opposed to having to wait for these experiments to be carried out. And just to explain what conventional mass spectrometry is for those who aren't aware, effectively you're sort of destroying your sample, you're vaporizing it, you're breaking it up. And as you break it up, the sample gets broken up into ions, and you have a source of ionization. So you expose that to the vaporized samples, and therefore you get charged particles. And those charged particles get pushed through a vacuum and they get accelerated. And at the end of it, and that vacuum has a magnetic field. So according to the mass and according to the charge of those vaporized compounds, a detector will have hits in different areas. And where it has hits, that's where we then get these spikes that we often then see. And those are the ones that you will see when we present our data. But really all of that takes quite a lot of time to do. But it's very helpful. And we've certainly used this technology in varicose veins, identifying certain metabolites associated with varicose compared to non-varicose veins. And more recently, identifying a pilot signature predictive of ulcer healing, which is currently undergoing validation by one of my PhD fellows. But as I've mentioned before, mass spectrometry is destructive. You have to vaporize your sample, so the sample is no more. You can't use it again. But the sample preparation really is very cumbersome, and therefore there's limited applications in translation. The time that is taking most of sort of the issue really is this ionization and being able to sort of get that detection in the magnetic field. So actually, if you have ionization in an ambient environment, which basically means in the environment where it is, so without having to take it to the lab, all of a sudden you can get the results a lot quicker, because it takes a lot less time to run through the vacuum and then do the detection. That is all instantaneous. Really is the ionization aspect that takes the longest. And that's why the development of ambient mass spectrometry has really changed things completely for us. And for example, it's used to get real-time information so for example, in border control as well, so to detect certain chemical compounds when it comes to drugs, etc. Mass spectrometry does get used in a lot of areas that we don't even realize necessarily. But it's very helpful with potentially allowing in vivo analysis. And there are different types of methods to perform ambient ionization. Some that really can be performed in real time, and some that can be performed in real time using a sample that you've taken from a patient, which is DESI. So if I start with desorption electrospray ionization, This is just a different way of effectively ionizing the sample. You use an electrospray of a specific solvent, usually methanol, that you apply to the sample. The sample then has some charged droplets that then get taken into the machine. But you can't really spray patients with methanol all the time. Therefore, it's very good to use if you have biopsies, if you have tissues that you take from patients, and you can get answers fairly quickly, but you can't really use it in clinic or in theatre on the patients as such. So one other way of using it, apart from biopsies, is by using an intermediate collection point, such as a swab, for example. So if you use the swab on diabetic foot ulcers or on venous leg ulcers, the idea is that you can collect some of that fluid that gets absorbed, and then in real time you can analyze that swab to immediately get the results. And here we've got a video of one of my research fellows called Jaya. She's doing diabetic foot research. And as she holds the swab to the machine, you immediately get the spectra in real time. So you can get answers really quite quickly. And these spectra, again, usually this is all inflammatory and very much in the lipid region, which is what she has found in this small pilot. And again, in venous leg ulcers, again, lots of spikes in the lipid regions as well. As a proof of concept work, we have compared some of these swabs to porcine liver controls, which we use as sort of our testing groups to make sure that the experiments are being conducted appropriately when we look at the multivariate statistical analysis. And you can see here that there's clearly a big separation between the ulcer swabs and the pork liver control. Interestingly, I mean, this is, again, very preliminary data, but depending on what kind of reflux patterns patients had, whether they had superficial reflux only, combined reflux, or just functional status with a normal duplex ultrasound, you can see that there's clustering of individuals within these different categories. So there may be some relevance with respect to mapping hemodynamic burden of disease as well, which is a point of interest. In addition to the swab, what we really wanted to do was see whether we could get an imprint of the fluid that's on top of the ulcer, so that we don't just get the fluid being laterally translated into a swab and identifying what metabolites are there, but so that we can see what metabolites are around the ulcer edge as opposed to in the middle of the ulcer, all based on an imprint of that fluid. And so we decided to use non-adherent silicone dressings, which we initially tried on, again, porcine liver, and in the proof of concept aspect and methodology development work. And we can see here that we get different types of signatures for porcine liver and porcine kidney compared to the blank control, which has almost nothing in it, as you'd expect. And when we use these non-adherent silicone dressings on venous leg ulcer patients, we are able to identify metabolites in a non-invasive manner, and we can identify them as early as from having the non-adherent dressing on for 5 seconds. However, the maximum yield is at 30 minutes. So there's a little bit of work going on there with respect to how best to use that in clinical practice, but it's very interesting to see that actually this is very, very sensitive, even just with only a few seconds on the patient's ulcer. And there's some patterns here with respect to healers and non-healers in this volcano plot. So using the data from these ulcer imprints can provide quite a lot of information from a biological perspective. And with respect to the actual compounds, those are being formally analysed at the moment. As I mentioned before, tissue biopsies are sometimes used to try and identify biological processes going on within the ulcer, and that's where DESI-MS imaging is very helpful. And really, this is metabolic mapping. You can see here an example using a leaf, and you get different hotspots for different metabolites within that leaf's skeleton in a way. And it's metabolic immunohistochemistry, effectively. So you take your biopsy, you freeze it, you put it into a hydrogel embedding, hydrogel embedding setup that you can then cryostat. So you get very thin sections, and those sections can then be analysed using DESI. And you get a much greater degree of information with respect to the different masses and charges and compounds that you see within different areas of these biopsies compared to your standard H&E staining. So really this provides a lot more information and therefore can be very helpful to further characterize things such ulcer edge biopsies and try to better understand what sort of biological processes are going on. But the thing that I think is most exciting is REAMS, which is rapid evaporative ionization mass spectrometry. And the reason for that is that you absolutely do not need any preparation. You don't need a swab, you don't need a biopsy, you don't need anything. You need the machine, and you need to have an intermediary that allows you to sample the tissue in real time. So the initial work was done with what's called the iKnife, which is very much used in cancer surgery to identify resection margins. And what they've done is attach the mass spectrometry machine to a surgical diathermy device. And as the surgical diathermy device cuts through the tissue, the plume of diathermy smoke that you get gets sucked away and sent to the machine, and that is analyzed for metabolites. And it has very high sensitivity and specificity to identify metabolites from cancerous tissues that you are resecting versus normal tissues. And you can imagine in cancer surgery, where you maybe have difficult resection margins, you can't quite tell where you are. The olden days, you take the sample, send it off to the histopathologist and wait in real time for them to tell you whether it was cancer or not. You can get that data in theatre in real time immediately without having to wait. So it has huge potential, and now is being assessed in prospective randomized controlled trials in breast surgery and colorectal surgery. And we were very interested in this and thought maybe there's some applications to venous leg ulcers as well. But what intermediate do you use? Do you use surgical diathermy? Well, we don't tend to diathermy venous leg ulcers. That's not how we treat them. So the first idea was with respect to the VersaJet device, and some of you may be familiar with it, but it's this hydrosurgical debridement system, which is used often by the plastic surgeons and by us. And you can set different degrees of depth of debridement, but really it's just a jet of high pressure water and with a Venturi effect at the nozzle, which means that you get this mist created as you're debriding with the water. And that little cloud of mist is the intermediary that we thought we might be able to assess. The other aspect was CO2 lasers that are often used in dermatology. They're highly precise. They have a predictable depth of penetration. And you can actually use them with causing very little damage to the skin, but with ionization of the most superficial area of the skin, which is non-destructive, but enough to be able to get a small amount of plume and a small amount of mist that can also be assessed using REAMS. So we first did the proof of concept with respect to coupling this hydrosurgical debridement system. And as I've mentioned before, it's this Venturi effect, but you really need to be able to collect the mist. It's not like this sort of happens naturally. So one of my PhD students, you can see there in the video, that mist that we are talking about, designed and then 3D printed a nozzle applicator to then allow a tube connection for the mist to be sucked into the tube and sent straight to the machine that you see in the big picture on the left-hand side. That's the REAMS machine. This is our Theatre 9 at St Mary's Hospital. It's a hybrid theatre where we do all our operating. But, it's a big machine, but it's not a huge machine. You can imagine it be able to fit in any surgical theatre, and that is what is able to identify these metabolites in real time. We initially did a porcine tissue pilot, and you can see here one of the fellows is analysing porcine liver and porcine kidney. And because the machine has been taught what the typical metabolites are for porcine liver and porcine kidney, it is able to recognise them with a very, very high degree of accuracy. But this is easy because we've tested porcine liver and porcine kidney lots of times, therefore the machine knows exactly what they look like. The difficulty comes with how do we teach the machine what is a healthy or an unhealthy ulcer? And that's really the topic of this fellow's PhD students. So we wanted to categorize unhealthy, borderline, and healthy tissues when debriding these venous leg ulcers. And really what that entails is if you're wanting to map this spectrum of what's unhealthy to healthy, with the metabolites that you're seeing as you're doing the debridement, then effectively you need a video so that you can annotate what is healthy and what is unhealthy as the operation is going on, and you can compare it to the metabolites that you're seeing on the screen. So it's second by second sort of matching, which takes a lot of work, but that allows us to be able to teach the model as to what is a typically healthy wound and what is a typically unhealthy wound. And that allows it to learn what metabolites it needs to look out for so that it can predict as you're then debriding, similarly to the pilot, what is healthy and what is unhealthy. So this is really that work where we've got specific spectra at the beginning, which are very unhealthy. Actually, there's not that many spikes. And at the end of the procedure, you can see there's really a lot of content there. And that is the sort of raw wound, if for want of a better sort of definition. And when we classify these tissues, we are able to, having sort of high degree of correct classification, even in the early models, good separation between the healthy and non-healthy tissues. But we don't really need a machine to tell us what's healthy or what's unhealthy. We have our eyes. It's not terribly helpful as such. But what we do want to know is the depth of debridement, just to make sure that then we're not over debriding a wound, for example. That would have a good clinical application. And again, if we're trying to compare sort of healthy and borderline with non-healthy, you can see that, again, there's high sensitivity and high specificity with a really good accuracy. So this was the first time that the VersaJet device was coupled with Reams, and therefore we're hoping to continue this work moving forward so that we can use the data to be able to predict healers and non-healers once we have a better picture as to what their metabolic profile is. And finally, we decided to couple Reams with the CO2 laser. The VersaJet device is very good, and we personally don't use it. It's Imperial routinely in the outpatient clinic. I know in certain units they do, but we did wanted to have a way of analyzing the metabolites in real time in clinic, so patients can just come for their appointment, be tested, and then go. And that's why we decided to couple this to the CO2 laser. Again, we created a custom 3D attachment that was printed to be able to transfer some of that aerosolized smoke or mist from the CO2 laser straight into the machine. Again, porcine tissue pilot with the ability of the laser to reliably, correctly classify both kidney, cortex, medulla, and liver. And you've got a nice video there of the laser being used in the kidney cortex. It will now move to the medulla, and you will see that the machine is going to be able to recognize it within a matter of seconds and off to the liver. And again, initially doesn't know what it is, it's an outlier, and then it correctly categorizes it. So we did the first human study in venous leg ulcer patients, so patients coming, having small amounts of anesthetic to the area, and then having the CO2 laser applied to the biofilm, to the wound bed and the wound edge and the adjacent skin. They clearly have different features from a spectral perspective with respect to their metabolic profile. Again, in terms of the tissue classification model, we get a lot of clustering of sampling of specific areas. So the biofilm being separate to the wound bed, being separate to the wound edge, and so forth. And actually with good, correct classification rates, even in this initial pilot study. Again, if we look at the biofilm in greater detail, and we were interested to try and map that in more detail, again, it's able to recognize what is biofilm and what is the wound bed. And again, that falls back into when do you stop debriding? Have you cleaned the wound successfully? And the biofilm definitely has a very different metabolic profile to what the actual native wound bed is like. And again, these are just volcano plots showing that there are a number of compounds that are more highly expressed in the wound bed compared to the biofilm as well. And this project is currently being carried on by a couple of our research fellows looking at skin changes in patients with venous disease, having assessed it in C6 patients and characterized the ulcers in detail. We now want to see whether there's a metabolic difference between patients with different skin manifestations of venous disease and what those are. So in conclusion, I think there are great benefits of ambient MS technology in vascular research. It has great advantages compared to standard MS. It's a lot more accessible and a lot easier to bring to the patient's bedside. And hopefully that will allow us to integrate this technology in the future with respect to both research, but also with routine clinical care. And that's it. Thank you very much.
Thank you. This sounds really, really exciting, especially bringing this machine to the operating room and the bedside. You mentioned briefly that you're also looking at those wounds that don't heal and those that do heal and looking at the analysis. That might be very helpful for clinicians in terms of identifying which wounds we need to be more aggressive with or which ones are already on on the route to healing, and how to, because very often we don't really know when the patient comes into the clinic, is this large wound going to be able to heal or not? And what can I do to try to change the proteomics to try to get this wound to a healing state? So I think this sounds really exciting.
Yeah, I mean, it has certainly great applicability. We've sort of been developing two lines of research at the same time, where there's the biological assessment and in-depth sort of metabolomic and proteomic analysis to really identify what metabolites and what proteins are present in these wounds and whether they do correlate with prediction of healing or not. Because clearly we had the pilot data that needs validating, and in the validation work that one of my PhD students is doing, that is being looked at in a lot more detail. So that will provide the scientific information to then be able to interpret when it's detected by these new technologies that we're developing at the same time. So we're trying to develop the science and the translation to patient care. So certainly, I think it's very promising what Reams is able to do, and the fact that we can detect these in real time. But I think the strength of it will come once we have a really good idea of what metabolites are present in these wounds and which ones are the most important in terms of correlating with healing potential. Because then you can have a patient and you know what the signature is. You have the patient, they come to clinic, you zap them with a laser, and you go, oh, you're going to be a non-healer. And we don't understand why some of these are non-healers and others are, et cetera, but at least you can identify the ones that are at risk and are likely not to heal. And therefore you can provide more aggressive therapy, more closer follow-up. You can personalize their treatment, as opposed to maybe somebody else coming who has a metabolic signature that puts them in a healing category, and therefore they will probably do well. So I think trying to pick out those individuals who are hard to heal and are at high risk of recurrence is really important, so that they can have the right treatment for them, as opposed to just having a blanket sort of one size fits all approach. But I'm also hoping that this sort of data will be able to help us understand a little bit more what it is that makes people different, and why people with the same degree of reflux come in with such different presentations. And is it a problem with the skin? Is it a problem with something else? And hopefully some of the skin analysis maybe will yield some data that might be interesting in this area.
I'm also wondering if it might be able to identify some of the changes that take place in these wounds with therapeutic interventions, specifically helping target which therapeutic interventions may be able to help certain patients or certain wounds for that matter. It sounds really exciting. It sounds like it has a lot of potential, really getting down to some of the molecular mediators, and some of the possibly even further than this. So thank you very much for your great work. Thank you for presenting it so easily, simple, and clearly. Thank you.
Thank you very much. It's a complex area, so I hope it was clear enough. But yeah, thank you.